Dear colleagues, dear friends, it is my great honor to give a presentation here. And my title is Prostate Biopsy, Multiparametric MRI and Transrectal ultrasound fusion imaging and second eye ultrasound. And I'm from Shanghai, China. First, the background. As we know, the incidence of prostate cancer increased significantly in recent years. And in the United States, the prostate cancer accounts for nearly 20% of the newly diagnosed cancers. And the incidence rate of prostate cancer is increasing year by year in China also, accounting for the seventh of the new malignant tumors in male, with the 10th mortality rate. The pathological features of prostate cancer is that the prostate cancers are mainly thinner adenocarcinoma, and the other types are very rare. The progress of prostate cancer is very slow, and the nature course can last for decades. And in the pathological specimen, prostate cancer is always scattered and multiple. The diagnostic method for prostate cancer include the prostate-specific antigen and digital rectal examination, and imaging include ultrasound and MRI and systemic biopsy. All of the methods have their advantages and disadvantages. For example, the PSA has a very sensitive, and however, the specificity for PSA is very low. So it is always used for screening of prostate cancer. For DIE, it has very high specificity. However, the sensitivity is very low. And for the imaging findings of benign and malignant lesions may overlap. So the imaging, especially the ultrasound, is always used for biopsy guidance. And the systemic biopsy may have some false negative results, and it is invasive. However, systemic biopsy currently is the gold standard for a diagnosis of prostate cancer. It implies that the pathological type can be diagnosed and the Gleason score can be evaluated by systemic biopsy. With regard to the prostate-related guidelines, we mentioned the European Association of Urology. In this guideline, the role of imaging in clinical diagnosis mentioned that transrectal ultrasound and ultrasound-based techniques, such as grayscale ultrasound, is not reliable at detecting prostate cancer, and sonar elastography and contrast enhanced ultrasound are still under investigation and not ready for routine use. mpMRI associated with T2 weight imaging with at least one functional imaging technique has good sensitivity for the detection and localization of ISUP grade 2 cancers. So mpMRI is increasingly used to localize suspicious areas that could be targeted by so-called MRI targeted biopsies. With regard to the ultrasound diagnosis of breast cancer, it has many advantages such as convenient, fast, and non-invasive. It can show the calcification and the inflammation easily, and it can use to guide the prostate biopsy, and the systematic puncture reduced prostate cancer rate mortality by 21%. However, it has also has some disadvantages that ultrasound cannot find lesion in many of prostate cancers, and the sensitivity and specificity for staging is relatively low, and the application of transrectal ultrasound led to unnecessary biopsy and up to 50% of prostate cancer with no clinical significance, and also biopsy may also associate with some complications. And on ultrasound, there are some suspicious ultrasound features of prostate cancer, such as hypoechoic nodule in the central gland and focal area of increased vascularity in gland, and diffuse hypoechoic area or irregular or ear-defined capsule, and focal elevation of capsule, and hypoechoic nodule plus elevated capsule, and the combination of these suspicious features. For example, in the left peripheral gland of these prostate, there is a cancer here, and this is another type of prostate cancer. And this is ultrasound image of benign prostatic hyperplasia, and this is a chronic prostatitis, and this is a focal prostate cancer, and in this case we can see diffuse prostate cancer. And we can also use the multimode ultrasound for prostate cancer. For example, in this case, we can see a lesion at the peripheral zone of the prostate, and we can see increased blood flow in the lesion. And on Power Doppler imaging, the increased vascularity, and on contrast enhanced ultrasound, we can see focal hyper enhancement at the peripheral zone of the prostate. And for shear wave elastograph, you can see the increased stiffness of the lesion, and on the strain elastograph, you can also see the increased stiffness of the prostate cancer. For multiparameter PIRUS, this is the recommendation from the European Association of Urology. As compared with traditional ultrasound-guided prostate biopsy, MRI targeted biopsy could efficiently increase the detection rate of clinically significant prostate, while decreasing cost of required biopsies and reducing the unnecessary diagnosis and treatment of clinically insignificant prostate cancer. So the concept about the clinically significant prostate and insignificant prostate cancer. And the latest EU guidelines has recommended the usage of PIRUS for acquisition and the interpretation of mpMRI data, and suggest that the targeted biopsy should undergo in cases of PIRUS score 3 to 5. And so what is the meaning of the clinical significant prostate cancer? This concept is very important. For the clinical significant prostate cancer means the Gleason score is greater than or equal to 7. These lesions have the basic characteristics of most malignant tumors, including steroid-invasiveness and high risk of metastasis. They often have capsular invasion, infiltration of surrounding tissues, and large volume, which cause serious harm to the patient's life and quality of life. However, for the non-clinical significant prostate cancer, the Gleason score is less than 7, and it is always small prostate malignant lesions, and it is relatively inert and have a low risk. So this is the advantage and the disadvantage of the multiparameter MRI. So this is multiparameter. The anatomical structure of prostate is clear, and the sensitivity and specificity for prostate cancer are very high. And it also has high sensitivity in assessing the tumor progression and staging. The most important is that the mpMRI can avoid 27 unnecessary biopsy and improve the detection of clinical prostate cancer by 18%. However, it also has some disadvantages such as inflammation and bleeding are difficult to distinguish, and direct guidance with MRI is time-consuming and laborious. And for the mpMRI-TRUS, the TRUS was first published in 2012. We standardized the prostate MRI report and has good clinical application value. And the TRUS was developed and released in 2014 as the TRUS version 2. And TRUS version 2 is convenient to use MRI data for targeted biopsy, propose risk level, and guide clinical evaluation of malignant degree of prostate cancer, and probably manage the patients with prostate cancer. So this is the TRUS score of the prostate lesions. TRUS 1 means the risk for malignancy is very low, and the TRUS 2 means the clinical significant cancer is unlikely, and TRUS 3 means it is intermediate. It means that the clinical significant cancer equivocal, and TRUS 4 means a high possibility of clinical significant cancer, and TRUS 5 means the possibility is very high. Is very high. So this is the TRUS score for the peripheral zone and transition zone of the prostate lesions. Because of the time limit, I will not describe it clearly. And this is a DCE score. DCE score of the prostate lesion. And this is a TRUS score for the lesion in the peripheral zone. So for the lesion in the peripheral zone, the mean DWI and ADC was observed. Meaning the DWI was observed. So when the DWI score is 3, evaluation of dynamic contrast enhanced imaging should be added. If the DCE is positive, the final TRUS score is 4, and if DCE is negative, and the final score remains 3 points. So this is for the peripheral zone lesion. And for the transition zone lesion, T2 weight imaging is very important. And for when the T2 weighted imaging score is 3, the DWI score shall be given. When the DWI score is 5, the total score will be changed to 4. Otherwise, the total score is still 3 points. Indication of, so we can see that the TRUS is very important. It's an indication for the ultrasound MRI fusion prostate biopsy. It can be used, the fusion transperineal prostate biopsy can be used in the first or repeated biopsy on operative PAS score are greater than 3 points. So we will move to the fusion imaging of multiparameter MRI and transrectal ultrasound. So why we need the targeted biopsy under the guidance of fusion imaging? Because the traditional system biopsy has some limitations. For example, for the transrectal ultrasound, lesions between the needles or before the needles or in the transition zone or in front of the ureter. These areas are very hard to be achieved. And for transperineal ultrasound, also there are also some areas cannot be achieved by a traditional systematic biopsy. And the limitation of systematic biopsy includes it may miss the clinical, the red one. This means the clinical significant prostate cancer. For traditional biopsy, it might miss the significant cancer, and here and miss the portion with high infiltration, or increase the direct detection of non-clinical significant PCA. For example, the pink one means the PCA with no clinical significance. However, by using the traditional biopsy, it will be detected. So the MRI-guided targeted biopsy included cognitive fusion, all the biopsy under the direct guidance of MRI, all the software registration of stored MRI and the real-time ultrasound. The biopsy is also named as the biopsy using fusion device. This is the cognitive fusion. It will depend on the experience of the operator. And this is the MR transrectal ultrasound fusion guided systematic biopsy and targeted biopsy. It is accurate, it is faster, and it is very safe. For example, in this case, this is a 71-year-old male patient. The physical examination showed increased PSA and benign prostate hyperplasia, and the PSA is elevated. And on baseline ultrasound, we cannot see any lesion in the imaging, including the B mode and the color Doppler ultrasound. On MRI, we can see that there is a hypointense signal in the central zone at 11 o'clock. And on the dynamically contrast enhanced MRI, it showed hypo enhancement. And here we can see that the ADC value is significantly reduced. So we perform MRI ultrasound fusion guided CUS, and we can see that under the fusion imaging, we can see the lesion here. It's corresponding to the lesion on the MRI. We can see hypo enhancement during the arterial phase, a very small lesion. And then we select the MRI map with clear lesion. And then the lesion on ultrasound was labeled. And then we performed the fusion-guided biopsy. You can see that the lesion is here. It has no any evidence on conventional ultrasound. However, under the fusion imaging, we can guide the lesion very accurately. And this is the pathological results of the biopsy. For the conventional systematic biopsy, all the 12 cores are benign prostate tissue. However, for the targeted biopsy, in the 4 scores, 2 scores are benign. The other 2 scores, the other 2 cores are prostate cancer, and the Gleason grade is 7, which means it is clinically significant cancer, and the cancer accounts for nearly 30%. And this is another case, and the patient also has a elevated PSA level. We cannot see a lesion on conventional ultrasound. However, on contrast enhanced ultrasound, we can see a hyper enhancement in the transition zone of the prostate, indicate that there must be some suspicious lesion here. And the lesion was confirmed by the MRI. We can see that it showed hyperintense on T2 imaging, and it showed remarkable hyper enhancement on dynamically contrast enhanced MRI imaging, and it has a very significantly decreased ADC value. So MRI ultrasound fusion also performed. You can see that here on the ultrasound imaging corresponding to the significant dark area on MRI imaging, and then the biopsy is performed. You can see the leader targeted lesion. And this is the pathological results. For the conventional biopsy, all 12 cores are benign tissues. However, for the targeted 4 cores, 2 cores are a benign tissue, and the 2 cores are adenocarcinoma. And the Gleason grade is 6. This is another patient. Also has elevated PSA level. You can see that the image is not very complex. However, no obvious lesion is seen on ultrasound. And the MRI clearly detects the lesion. You can see the size is about 13 millimeters. And MRI ultrasound fusion guided CUS confirmed a hyper enhanced area in the transition zone. So ultrasound, the fusion guided biopsy is performed. And the pathological results, the 12 course of conventional biopsy, all are prostate tissue, no cancerous tissue. However, for the targeted biopsy, all the 4 cores are prostate cancer, and the Gleason grade is 7. So that is very important. Only the targeted biopsy can achieve the correct diagnosis. And this is another lesion. PSA is very high. We can see that there may be a lesion here on ultrasound and increased blood flow. And this is the contrast enhanced ultrasound. You can see a significant hyper enhancement in the early phase. And MRI, the imaging, the cancer is very clear. is very clear, remarkable. And also the fusion imaging, ultrasound correspond to MRI imaging very well. And biopsy is carried out. And for this patient, the conventional biopsy also achieved the diagnosis of prostate cancer. However, the targeted biopsy achieved the prostate diagnosis, cancer diagnosis. The Gleason score is 9. It is higher than the conventional biopsy. The conventional is 8. So the advantages of fusion targeted biopsy include it can use to find the missing prostate cancer areas in routine systematic biopsy and improve the detection rate of prostate cancer. It can obtain the tissues with higher Gleason score, which is helpful to determine a treatment plan. And more tumor tissues can be obtained by a targeted biopsy. And then we'll move to the other section about second look transrectal ultrasound. We know that the PIRUS has some limitations. For example, the consistency of PIRUS reader is not enough, and the consistency of cuff value is only 0.4. And the accuracy of prostate cancer in PIRUS 3 and 4 is only 25% and 39%. Because of the large amount of imaging information and the difference of regions with various levels, it is difficult to be applied to medical units at all levels. So in this series, we have 188 lesions in 156 patients, and the lesion size is about 30.9 millimeters, and all lesions were located in the periphery in 64% of the patient, and in the central zone in 36 patients. And the detection rate of prostate cancer based on the targeted biopsy, systematic biopsy, and the combined system and targeted biopsy were 56%, 53%, and 63% respectively, which means that the combined systematic biopsy and targeted biopsy can achieve the very high detection rate of prostate cancer. And according to the PIRUS classification and the PIRUS 3, 4, and 5 include 48% and 39% and 13% of the lesions. And of all these lesions, 167 were visible by second look ultrasound guided by the fusion imaging, while the remaining 21 appeared as non-mass type. Of the non-mass types, the detection rate of PCA were 19%. All were clinical significant prostate cancer lesions, and all were detected by a targeted unknown. So the targeted biopsy is very important for this non-mass type prostate cancer. And of the 4 clinical significant prostate cancer lesions with non-mass types, 2 were PIRUS score 3, and 2 were PIRUS score 4. This slide shows the relationship between the detection rate of prostate cancer and the PIRUS. For the PIRUS 3, only 20% were diagnosed of prostate cancer. And for the PIRUS score 4, about 80% were diagnosed as prostate cancer. And for the PIRUS score of 5, nearly 100% of the lesions or prostate cancer. So the necessity of a biopsy in PIRUS 3 patient is very important, because only 20% were prostate cancer. So we have an idea that if we can further divide the PIRUS 3 into different levels, which may avoid an unnecessary biopsy. For example, in this lesion, this is the MRI imaging. And the second look of ultrasound, you can see that lesion is very large. And the prostate cancer, we show visible lesion. It is also located in the peripheral zone. It also shows hypergeneticity, and it always has irregular margins, and it always cling to the capsule, and it always show the feature of tall, wide shape, and it always have the symmetrical vascular structure. For example, this side shows increased blood flow. However, compared with this side show nearly no blood flow. And this is another case, second look ultrasound. It's very clear, corresponding to the MRI imaging. So this we analyze the second look ultrasound features of the prostate cancer, and we can show that the exogeny, the margin, the shape, the border, and the symmetrical vascular structures are very important predictors for malignancy. So we further divided the none of the above described 5 significant predictors. If the patient have none of the above described predictors, the probability of the prostate cancer is very low. However, if they have the 5 significant predictors, the probability will be very high. So the fatal probability of prostate cancer increase as the number of suspicious ultrasound features increase. So we modify the PIRUS according to the second look ultrasound features. There's 3A, 3B, 3C, and 3D. 3A means no suspicious ultrasound features. 3B means only one suspicious feature. 3C, 2 or 3. 3D, 4 or 5 suspicious ultrasound features. This means the 3A, 3B, 3C, 3D. So the PCA, the detection of PIRUS 3A was 0, and it avoid the MRI-guided targeted biopsy in about 70% of the patients with PIRUS 3 lesions. So in summary, the risk stratification of prostate cancer with the application of mpMRI ultrasound fusion imaging directed second look ultrasound feature is very promising for clinical practice. So the revised PIRUS could omit unnecessary multi-parameter MRI targeted biopsy. Thank you very much for your attention. That's all. Thank you.